Okay, hello. Today we will hold our next lecture on medical radiology and we'll discuss radiological imaging of central nervous system. The central nervous system is composed of the brain and spinal cord. Spinal cord connects the brain with the peripheral nervous system. Spinal cord is comprised of cells, bodies, and axons that carry messages afferent and efferent. Afferent towards the brain, its sensory function, and efferent away from the brain. They support motor function. The peripheral nervous system includes all nerves outside the brain and spinal cord. It may be divided on somatic nervous system, which carries sensory messages to brain and motor commands to the muscles, and autonomic nervous system, which regulates autonomic body functions such as heart rate, breathing, and so on. Autonomic nervous system consists of two parts: sympathetic, which support function, fight or flight or motor activity, and parasympathetic, which dominant when relaxed. And of course, among all these, our predominant interest is first of all brain and spinal cord. Here is parts of nervous system: brain, spinal cord with 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, and parts of brain. 2 hemispheres, cerebellum and brainstem, also hypothalamus and pituitary gland. Basic imaging of central nervous system. As for many others organs and systems we have observed previously, there are X-ray, computed tomography, magnetic resonance imaging, interventional techniques such as angiography, myelography, and CT or MRI guided biopsy, also ultrasound and nuclear medicine, especially positron emission tomography. And how do you think why magnetic resonance imaging is printed in bold? Because it's the most accurate methods for diagnosing diseases of the central nervous system. Really have advantages before all other methods. X-ray of central nervous system, plain X-ray, is in limited use. Brain and spinal cord are invisible, and only bones, fractures, calcifications of foreign body may be evaluated with X-ray technique. Common terminologies used to describe central nervous system radiological findings. In plain X-ray, it's first of all opacity. Opaque or dense area on the X-ray appears white on the film. Sclerosis, thickening and increase in bone density appears white on X-ray films, also white. And radiolucency, non-opaque area on X-ray appears as dark or black areas. Ultrasound is also of limited use because ultrasound waves cannot pass through skull bones. Indications for ultrasound in evaluation of central nervous system problems is, first of all, evaluation of intracranial diseases and anomalies in children with open arterial fontanelle, such as hydrocephalus, intraventricular hemorrhage, subdural effusion, various congenital anomalies, and evaluation for spinal dystrophism in neonates and young infants. Terminology used to describe ultrasound findings. First of all, its echogenicity, or intensity of echoes reflected by tissues or structures from inside the body. We call hyperechogenic an area with higher intensity echoes in comparison to another appears brighter. Hypoechoic, an area with low intensity echoes in comparison to another areas usually appears darker or blacker on ultrasound scans. Anechoic, an area which with no echoes also appears black. And isoechoic, an area with the same or similar echo intensity in comparison to another area appears similar. Technique of CT examination. Head computed tomograph scans are performed at an angle parallel to the base of the skull or parallel to orbitomeatal line. Slice thickness is generally between 5 and 10 millimeters. The patient is lying supine on the table. With the help of CT, evaluation of tumors, infections, and some stroke cases may benefit from the use of contrast, but contrast is not used in the routine head CT. Density of different tissues and different objects in CNS evaluation, you see that such objects as white matter and gray matter are quite close to each other, measured in Hounsfield units, and of course they will be hardly distinct by eye. These different colors of gray will be hardly distinct by eye of operator, of radiologist. It's essential limitation for use CT for CNS study. What is bright and dark on CT? First of all, I should say that CT scans are readily available fast modality for evaluation of intracranial structures. It supports rapid acquisition of axial images. The procedure of choice for evaluation of patients with head trauma and stroke patients, and provide very fine details of the bony structures. And let's now try to answer our question: what is bright and dark on CT? The rule is the following: the more dense the tissue, the brighter it looks on CT. Any calcified structures, like the skull bones, appears bright or white. New hemorrhage in the brain is also bright. Water or cerebrospinal fluid looks dark on CT. And we call darker structures as hypodense or low density, and brighter structures are called hyperdense or high density. Here is a very nice mnemonic rule that can be used when faced with the interpreting of CT head scans. Blood can be very bad. Think of this approach as a framework for a quick review of the scan. It won't turn you into experienced radiologist. It's important to recognize that more subtle things might still be overlooked. Furthermore, you should work through the entire system even if you spot something obvious early. Or, for example, if you see a large extradural hematoma, still check that cisterns, brain, ventricles, and bone for any other abnormalities. This CT scan shows acute hematoma as well as an associated cerebral contusion or bruising. The true midline has been outlined by yellow dots, and you can see that the frontal horns of the lateral ventricles have been pushed over to the left. In addition, the third ventricle is now not visible, and it's also extremely difficult to make out the basal cisterns. This scan demonstrates four of the features which are included on the early outcome form, namely midline shift greater than 5 mm, intracranial hematoma non-evacuated, cortical contusion greater than 1 cm in diameter, and obliteration of the third ventricle. This hematoma requires surgical evacuation, otherwise deterioration of the patient condition is inevitable. Angiography. It's a real-time X-ray study. During this procedure, a catheter placed through femoral artery is directed up aorta, abdominal aorta, into cerebral vessels. Then radiopaque contrast material, or dye in other words, is injected and lights up blood vessels that are being studied. Angiography is a gold standard for studying cerebral vessels. This technique used to visualize the inside or lumen of blood vessels of the brain. Indication for this procedure. Usually it is administered for patients with stroke or cerebral infarcts, patients with transient ischemic disease, and for preoperative evaluation in patients with certain tumors. A computed tomography angiogram or CT angiogram is a test that used X-ray to provide detailed pictures of the blood vessels of brain. A CT angiogram can show narrowed or blocked areas of blood vessel. The test can also show whether there is a bulge or aneurysm or a buildup of fatty material called plaque in a blood vessel. This picture shows blood supply of brain and which region, which lobe or part of brain is supplied by certain arteries. For example, arterial parts of frontal lobes receive blood from anterior cerebral artery. This is this area, temporal lobes of brain, from middle cerebral artery, occipital lobe from posterior cerebral artery, and also central parts of brain from lenticus striate artery and from anterior choroidal artery. MRI. If an abnormality found on MRI is dark, we describe it as hypointense. If anomaly is similar to a reference structure, we describe it as isointense. And at last, if it is brighter than a reference structure, it is hyperintense. On this T1 weighted sequence, the right parietal occipital lobe mass is less intense than adjacent parenchyma and is therefore hyperintense. On T2 sequence, the right parietal occipital lobe mass is similar in intensity as the cerebrospinal fluid and could be described as isointense to cerebrospinal fluid. And at last, on FLAIR sequence, both mass blue and surrounding edema green are brighter or hyperintense to the adjacent brain parenchyma. What can we tell about signal intensity? Comparison of images of a normal brain is in axial plane is presented. The head computed tomography images shows the dense skull as white, the brain as mid-gray, with poor differentiation of white and gray matter, and the cerebrospinal fluid as dark gray. And you see that it's very difficult to distinguish white matter of brain from gray matter of brain because they are at the same colors. On the contrary, T2 weighted magnetic resonance imaging shows the skull bones as black, the brain as a mid-gray shade with excellent gray matter and white matter differentiation, and the cerebrospinal fluid is white. In the table, colors of different structures on T1 and T2 weighted images are presented. The most common types of MRI images are so-called T1 and T2 weighted images. Here, these sequences from the same subject are presented. Let's try to understand what can show one and another modality. T1 weighted MRI images are useful to look at normal anatomy of the brain. Images whose design is to produce contrast between gray matter, white matter, and cerebrospinal fluid. T2 weighted MR images are useful to look at abnormal processes or pathology in the brain. T2 weighted images better than T1 in detecting tumors and infarcts. In summary, T1 weighted images can be recognized by black fluid, T2 or STEER modality, by white fluid, and contrast enhancement with gadolinium is given to enhance the T1 weighted images. Another types of magnetoresonance images are so-called FLAIR modality with suppression of liquid signals compared with the T2 weighted image. High signal seen on these images indicates a pathological process such as edema, infection, tumor, or areas of demyelinization, especially near ventricles. One more modality, so-called STIR, or fat signal suppression, the image which suppress signals from fat tissue so that only water remains bright. Fluid-filled spaces, cerebrospinal fluid, edema, or any other abdominal fluid look hyperintense on STIR, and fat very hyperintense. Abnormal low signal on the T1 weighted image and abnormal high signal on the STIR image indicates a presence of abnormal fluid. Which scan best defines the abnormality? You see that T1 weighted images are better in detection of subacute hemorrhage of fat-containing structures and for anatomical details. T2 weighted images are better in evaluation of edema, demyelination, infarction, or chronic hemorrhage. And FLAIR are better for edema, demyelination, and infarction, especially in periventricular location. Why? Because T1 weighted images provides good contrast between gray matter in dark gray colors and white matter, which appears lighter gray, while cerebrospinal fluid is void of signal and remains black, and fat is bright. On T2 weighted images, this regime provides good contrast between cerebrospinal fluid as bright object and brain tissue, dark areas. Fat also appears dark. Pathological process increase water content in tissues, which increases signal on T2 weighted images and shows up as bright areas. And at last, FLAIR removes signal from fluid from cerebrospinal liquid and is useful in the detection of subtle changes of at the periphery of hemispheres and in the periventricular region close to cerebrospinal fluid. Another regimen, one more regimen of MRI investigation is so-called diffusion weighted imaging. This regimen has many applications, but it most often through off in workups of ischemia and stroke pathology. It is important to have a rough understanding how diffusion weighted imaging works to properly interpret the images. Diffusion-weighted imaging detects when water or hydrogen protons are unable to diffuse freely. Normally, cells are packed closely enough that the water surrounding them can move or diffuse rather easily. This cytotoxic edema in ischemia, the cells swell secondary to failure of the natrium-kalium pump, and the space between the cells becomes very narrow. Subsequently, the water that normally surrounds the cells cannot diffuse as easily as becomes restricted. Diffusion-weighted imaging is very sensitive at detecting this change, becoming bright or positive within minutes after acute ischemia. When there is a tumor inflammation or other process that breaks down the capillary endothelium, water leaks out of the vessels, and there is an increasing amount of water surrounding the brain cells. This is called vasogenic edema. In this case, the water can actually diffuse more easily than usually because of the larger gaps between cells. Diffusion-weighted images will not be positive in these circumstances. One more option of MRI is so-called functional study. What is the difference between MRI and functional MRI? Functional MRI scans use the same basic principle of anatomic physics as usual MRI scans, but MRI scans image imaging methods MRI scans image anatomical structures, whereas functional MRI image metabolic function of brain. Functional MRI is a modern imaging method that allows you to localize the areas of the brain that are responsible for performing certain actions. Functional MRI is aimed at determining the activation of areas of the cerebral cortex at rest during mental work or physical exertion. During the examination, the patient performs special tasks. The device transmits information to the computer where the program performs mapping. Functional MRI is a non-invasive technique for imaging the activation of brain areas by different types of physical sensation, such as sight, sound, touch, taste, smell, and others. And functional MRI measures small changes in blood flow and therefore changes in oxygen levels and therefore in metabolic activity that occur with the brain activity over time after visual, auditory, and other stimuli, mental, arithmetic, reading, physical exercises, and so on, meaning which part of the brain is handling critical function. Thus, the images generated by MRI scans are like three-dimensional pictures of anatomic structure. The images generated by functional MRIs are images of metabolic activity within different anatomic structures responsible for sight, sense of smell, hearing, and so on. The scan, functional MRI scan, can help doctors to assess the effects of a stroke or other condition affecting the brain or spinal cord. I mean loss of certain function of the cerebral cortex. In particular, functional MRI can reduce the risks of microsurgery by helping the surgeon to identify areas of the brain that perform critical function such as speech, movement, perception, or planning, and to prevent damage of these regions during operation. The information from functional MRI images also helps a doctor to determine the most effective treatment or assess how well a chosen treatment is working. Look at this picture. You see that in functional MRI images, areas which are responsible for speech, in this case, and hearing, are very bright on functional MRI images, and this map is very useful for surgeon in those cases when they have intention to provide operations somewhere inside the brain. They should avoid to destroy this region. In other case, patient will lose function of speech and hearing after operation. CT and MRI scans usually have the same indications. These are infection or inflammatory diseases of central nervous system, congenital anomalies, trauma, and different tumors, benign or malignant. Very important options of CT and MRI technique is possibility to provide biopsy, stereotactic biopsy under CT or MRI control. This biopsy is necessary to confirm what type of brain tumor the patient has. You see that for this purposes, a special frame is constructed. Then a needle is inserted into a certain area of the brain, in the area of our interest, and then CT or MRI scans is performed, and when we ensure that the needle is placed correctly, we take a sample for morphological examination and confirm diagnosis of malignancy of brain. Next option for central nervous system, its radiological examination, is positron emission tomography. It makes use of radioactive tracer to measure cerebral blood flow. It's useful, first of all, in diagnosis of new onset tumors, including the differentiation between benign and malignant tumors. Also in determination of the stage of the disease, in the correct staging of pathology, including the identification of distant metastases. Also, evaluation of the effectiveness of treatment may be provided with a series of positron emission tomography scans. And in monitoring of patient, assessment of disease recurrence is also possible. Two isotopes most widely used for positron emission tomography of brain are phtor-deoxyglucose and carbon methionine. The difference between them is in half-life time. You see that for carbon it's very short, so you should hurry up to be in time to finish the study. And with deoxyglucose, these problems, and with isotope of phtor is don't trouble us, and so phtor deoxyglucose is preferable in positron emission tomography of brain. Now let's observe radiation syndromes of central nervous system damage. They are listed here on this slide, and these are group of pathologies, group of systems which have certain characteristic which allows to distinct them from other pathologies of brain and spinal cord. First of all, it's damage of the skull and the brain traumas, or skull fractures, sub- and epidural hematomas. The second syndrome is demyelination in multiple sclerosis or leukoencephalopathy. Acute ischemia, ischemic stroke type, chronic ischemia or encephalopathy, vascular origin, hemorrhage and hemorrhagic stroke type. So both most wide types of strokes are ischemic and hemorrhagic. Next syndrome, scar or atrophic changes, I mean local reduction of the substance of the brain with its replacement or enhancement of cystic gliosis, often as a result of vascular and demyelinating pathology. Another syndrome is blastomatous growth, the primary tumor of brain or brain metastasis, acute and chronic neuroinfection, encephalitis, meningitis, arachnoiditis, and at last cerebrospinal fluid hypertension. Let's observe briefly different syndromes of central nervous system damage. Skull fractures on CT. There is nothing difficult in searching and finding line of structure in the skull bones, but I should say that skull fractures on CT should be evaluated both in brain and bone window, because in brain window we see only fractures of bones, and in brain window reaction of surrounding tissues is also present. Hematomas, edema may be seen only in brain window if we perform CT to confirm skull fracture. Demyelination. Any diseases of the nervous system in which the myelin sheath of nerves is damaged. This pathology may be caused by genetic factors, infection, so-called acute disseminated encephalomyelitis, by autoimmune reactions, so-called multiple sclerosis, also may be as a result of chronic neuroleptic use of vitamin B12 deficit and influence of toxins, of household chemicals, alcohol, and so on. In some cases, unknown factors lead to demyelination, and we can't say why did this pathology happen. Radiological features of demyelination are localized. This pathology is localized in the white matter. The 40 right round or oval along perforated vessels. Usually these 40 are multiply and combined with hydrocephalus, increasing with the progression of brain atrophy. Vascular diseases of the brain are one of the leading causes of death worldwide. The mortality rate from circulatory diseases in the brain is about 24% of the total number of cases. In comparison, brain cancer as a cause of death is recorded by doctors only in 6% of all cancer patients. All vascular disorders may be diagnosed with CT, but MRI is still preferable. Two most frequent types of cerebral vascular events are ischemic and hemorrhagic. Ischemic is a result of thromboembolic process of vasculitis, dissection, fibromuscular dysplasia, venous thrombosis, and anoxia. Hemorrhagic events occurs as a result of arterial hypertension, of presence of aneurysms, of vascular malformation, congenital pathology, as a result of trauma, coagulopathy, and amyloidosis. Sorry. Stroke is a major source of mortality and morbidity, as we are talking about vascular disorders. Most strokes are ischemic, result from vascular occlusion by a thrombus or embolus. Magnetic resonance images must be initial modality to evaluate this patient in the first hours after onset. If later, severe complications may develop. Strokes, you see that ischemic strokes may be seen more frequently in 70–80%, and hemorrhagical event only in 10–15%. we should remember that hemorrhage vascular disorders have much poorer prognosis than ischemic diseases, and a half of all patients will die within the first months after the acute event, because hemorrhage not only breaks the brain cells but also cause also intracerebral pressure is increased, and this results in displacement of vital structures of brain stem, for example. In ischemic vascular disorders, patients have much better chance for survival. Vascular disorders on CT and MRI. On CT, CT scans usually becomes positive in first 24 hours after onset. Edema in a vascular distribution is present. CT is helpful to rule out intracerebral hemorrhage or hemorrhagic conversion, so-called hemorrhagic conversion, or secondary bleeding from ischemic infarction. MRI becomes positive earlier than CT in first hours after onset. Diffusion-weighted images can become positive even in few minutes from onset, and magnetoresonance angiography may be obtained at the same time to evaluate vascular occlusion. In the same time, I mean, you provide MRI scans, and one of options of this technique is to look not only on simple MRI pictures, but also reconstructs angiograms. Hemorrhage on CT at different times after onset. How long ago did the onset occur? Of course, it's a very important question. And what should we remember about this? Acute blood on CT scans is always bright. After 1 week from the onset, blood becomes isodense, approximately 1 week, and this area with blood is isodense to surrounding gray matter and can hardly be distinct with it. And at last, blood becomes hypodense at approximately 2 weeks after the hemorrhagical event. So from bright in first hours or days after hemorrhage, up to hypodense after 2 weeks. Early signs of ischemic and hemorrhagic infarction. On CT, we should observe loss of definition between gray and white matter, ill definition of internal capsule, and hypodense middle cerebral artery. In MRI, early signs of ischemic infarcts are T1 hyperintensity, T2 and FLAIR hyperintensity on diffused weighted imaging. These images are also hyperintensive, and decreased signal in perfusional images. When we compare the findings on T2 weighted images and diffused weighted images in time, we will notice the following. In the acute phase, T2 weighted images will be normal, but in time the infarcted area will become hyperintense. The hyperintensity on T2 weighted images reaches its maximum between 7 and 30 days. After this, it starts to fade. Diffusion weighted images is already positive in the acute phase and then becomes more bright with a maximum at 7 days. Diffused weighted images in brain infarction will be positive for approximately 3 weeks after onset. In spinal cord infarction is only positive for 1 week. And one more modality called apparent diffusion coefficient. This is values calculated automatically by the software from diffused weighted images. This regimen will be of low signal intensity with a maximum at 24 hours, and then will increase in signal intensity and finally becomes bright in the chronic stage. Magnetic resonance images allows us to determine a clear difference between hemorrhagic and ischemic stroke. In cases of ischemia, because of the occlusion of blood vessel, brain is deprived of blood supply, and ischemia appears as a broad dark area. And in cases of hemorrhagic stroke, area of hemorrhage is bright in elongated shape, as here. Aneurysms. Pathology. Aneurysms are local enlargement of blood vessels, of arteries, caused by weakness in the arterial wall. Often there are no symptoms. It's a silent pathology, but a ruptured aneurysm can lead to a fatal complication, and of course should be treated surgically and urgently. Aneurysm, as you see, are responsible for 75 up to 80% of subarachnoid hemorrhage and arteriovenous malformation or congenital anomalies of brain vessels are responsible only for not more than 5% of cases. And vasculitis also accounts for small proportion, not more than 1%, and no case found in 10-15%. Extra dural and subdural hematoma have different presentation on CT and MRI scans. Extradural hematoma is local, has a biconvex lens form bounded by the cortex bone, grafting and detached dura mater. So it's between cortex bone and dura mater. Subdural hematoma is extensive, has a crescentic form and often extends onto the whole hemisphere. Because the blood is spreading freely in subdural space. Syndrome of blastomatous growth presents such radiological features as nodular and multinodular lesions, irregularity of structures. Usually, blastomatous lesions are accompanied by perifocal edema, displacement of the brain structures may be caused by the presence of tumor into brain matter, and as a rule, primary tumor push normal structures aside when metastatic lesions, metastasis from other primary sites, it's through the adjacent structures. Here is on the pictures examples of metastatic lesion in the brain. It's metastasis from lung cancer and total destruction of areas of brain where this metastasis developed, and on the contrary, primary tumor of brain. In our example, it's glioblastoma on T2 and T1 weighted images causes displacement of normal structure to the healthy sites. For example, displacement of ventricles with cerebrospinal liquid. Liquid hypertension of cerebrospinal fluid. In case of this pathology, if this pathology develops, we will observe expansion of the liquid cavities of the brain and atrophy or rarefication of the brain matter on the edge of the ventricles of the brain. Compare normal MRI and MRI at liquid hypertension and hydrocephalus, where excessive accumulation of cerebrospinal fluid within the brain in form of butterfly. Volume of healthy brain tissue is reduced as a result of atrophy from fluid pressure on normal gray and white matter, and compare here is volume of white and gray matter on normal scans, and it's more thin on the scans with cerebrospinal fluid hypertension. Spinal cord compression develops when the cord is compressed by bone fragments from vertebral fractures, by tumors or abscesses, by ruptured discs intravertebral discs or by hematomas as a result of trauma. The most common cause is compression of the dural sac and its contents by an extradural tumor mass. Here on the picture, normal disc and different variants of disc pathology are presented as degenerative changes, bulging of disc, herniation, thinning or osteophyte formations, and presentation of spinal cord injury by herniated disc on sagittal T2 and T1 weighted images. You see that bright spinal cord on T2 weighted images is compressed by displaced intervertebral discs. In sagittal T1 weighted images, we observe the same, but not so clear as on T2 weighted images. To learn more about imaging of central nervous system, you have opportunity if follow these links, and as you understand, maybe our lecture is finished. Thank you for your attention, and the next lecture will be our last lecture. So I am looking forward for you, and goodbye. Now goodbye.